to all NEET PG aspirants. My name is Dr Ravichandra Karkal. I am the Psychiatry faculty for DigiNerve. Today we are going to discuss the questions that came from Psychiatry in NEET PG 2025. First, let's look at what were the key topics and areas where the questions have come from. One major area is schizophrenia and psychotic disorders. Schizophrenia like psychotic disorders, treatment of psychotic disorders, especially antipsychotics and their adverse effects. That is another area which was focused. There were also questions from trauma and stress related disorders. So we all know that traumatic incidents may cause the onset of some psychiatric symptoms, psychological symptoms. So there was also focus on trauma and stress related disorders. There was a question from personality disorder, and there were also questions from forensic psychiatry. So the intersection of law and psychiatry. So there were some questions focused on that also. And I would say the difficulty level was moderate, and of the 7-8 questions that had come, one question was really challenging. I think even some psychiatry postgraduate trainees may struggle answering that question, but most of the other questions were moderate level in difficulty. So let's begin with looking at the questions. So the first question was, a person attacks his co-worker complaining that the co-worker has been plotting to harm him. So basically this person thinks that the co-worker is plotting to harm him. He hears voices. Probably what they mean in the question is he hears voices which other people are not hearing, so he has auditory hallucinations. We can assume that. On examination, the person is found to have disorganized speech. Disorganized speech is a symptom of formal thought disorder. That is, we know very well that certain severe mental illnesses can cause thought disorder, and they can cause abnormality in the form of thought. That is, how we structure and organize our thoughts. So with these three things in mind, that he has an abnormal belief, a wrong belief that his co-worker is plotting to harm him, he is having auditory hallucinations, and he has thought disorder, formal thought disorder. With these things, we can come to a fair conclusion that this person may be suffering from schizophrenia or similar psychotic disorder or a delusional disorder, right? So he now has attacked his co-worker, right? So what would be the next steps? So the first option is refer for anger management. Definitely this is not just a case of somebody having excessive or abnormal anger. It is much more than that. It seems to be a severe mental illness where there is lack of insight, right? So it's a psychotic disorder. So it's definitely not just anger management that we are focusing on. Next is refer for psychiatric assessment and make him fit for trial, right? So whether the next option is whether you would just refer for psychiatric assessment and ensure that he can go to the court and fight for himself, right? Of course, with the help of a lawyer, right? The third option is he is not responsible because he is mentally ill. And the last one is start immediate trials and punishment. So you punish him because he has done definitely he has done something unlawful. He's attacked another person, right? We don't know what happened to the co-worker. If say he's ended up murdering his co-worker, then what usually happens is he would be tried in court because he's done an act which is against the law of the land, right? So now there are few things that you have to remember when answering this question. Just because somebody is mentally ill doesn't mean that they can be acquitted from crimes, okay? And everybody is sane in the court unless proved otherwise. So each citizen of India is assumed to have sanity. That is, he does not have any mental health issues, right? So everybody is assumed to be same unless proved otherwise. So now, can just because he is mentally ill, you can't just let him go, because he has conducted himself in a way which amounts to a crime. So option C is out of question. He is not responsible because he is mentally ill. Just because he is mentally ill doesn't mean that he is not responsible for a crime, right? And just because he has done a criminal act doesn't mean that he should be punished, because what we have to establish here is something called as insanity defense, right? Insanity defense, you must be remembering from forensic psychiatry, right? So McNaughton's rule, right? We have to establish that this person, when he did the act, whether he was mentally ill, we have to establish, and we have to also establish whether he had unsoundness of mind, because of which he did not understand the nature and consequences of the act. Then he did not understand that what he was doing was wrong. And third question is whether he did not understand whatever he was doing is contrary to the law of the land. So if we are able to establish that he was mentally ill when he did this act, he had such amount of unsoundness of mind which led to lack of reasoning, and he was not able to understand the nature of the act, that whatever he was doing was wrong, and whether it is contrary to law, whatever he was doing, then he can claim the insanity defense, and he can, his criminal responsibility will reduce. So criminal responsibility is covered under IPC section 84 or the Bharatiya Nyaya Samhita section 22, right? BNS 22 is the latest, laws, right? So the answer here is refer for psychiatric assessment so that you can answer all these questions that we discussed so far. The psychiatrist will do an assessment, or the forensic medicine expert will do an assessment and establish these things, right? And then we also have to establish whether he is fit to stand trial. Because, somebody who is severely mentally ill may just say that I don't want to, I've done a crime, just punish me. Because he may not be fit to stand trial. So we have to do an assessment to assess whether he is fit to stand trial. Also, we have to see whether he can be given some treatment and then the illness goes into remission and then he can be tried in the court. So the answer is B. Refer for psychiatric assessment and make him fit for trial. Moving on to the next question. A 45-year-old patient with 2-year history of involuntary movements. So there is a long-standing history of involuntary movements, right? Following long-term antipsychotic therapy. That is, this patient has been on antipsychotic therapy, which we assume is more than 6 months. Okay? More than 6 months of antipsychotic therapy with abnormal movements of the face, tongue and extremities. What is the most appropriate treatment for this condition? Right? So what are we dealing with here? Involuntary movements after long-term antipsychotic therapy. So these are adverse effects of antipsychotics, right? And the symptoms are also long-standing. For 2 years you are seeing these symptoms. So the diagnosis is tardive dyskinesia, a form of extrapyramidal symptoms that we see when we give antipsychotics to patients. And what is the treatment for tardive dyskinesia? Is it haloperidol? No, it is not haloperidol, because haloperidol is known to cause tardive dyskinesia when it is used for long term. Is it levodopa, which is a dopamine agonist? Dopamine agonists don't have a role in the treatment of tardive dyskinesia. Is it propranolol? Propranolol is useful in one form of extrapyramidal symptom called as akathisia. So it is not propranolol. So answer is valbenazine. Valbenazine is a vesicular monoamine transporter 2 inhibitor. Okay, it's a reversible inhibitor of VMAT2. So what it does is it will inhibit the uptake of monoamine neurotransmitters from the synaptic cleft to the to the vesicles in the neuron, right? So valbenazine has shown to be effective in the treatment of tardive dyskinesia, and that is the answer here. Now, the previous question itself has been formulated in a different way here, because these are recall questions. So patient with schizophrenia on haloperidol was responding well for last 2 years, now presented with orofacial dyskinesia. So these are abnormal movements that you see around the mouth or in the face. There are also coriform movements. What are coriform movements? These are jerky and very rapid movements, right? Like grimacing, blinking of the eyes, or grimacing of the face, or movement near the mouth. There are also tick-like movements, right? So again, it's very difficult to differentiate sometimes coriform movements and tick-like movements. Tick-like movements are also very quick, rapid, jerky movements, and also dystonia, right? So all these things can occur together. Again, the diagnosis, the question here is what can be the probable diagnosis and treatment, and as we discussed in the previous question, the answer is tardive dyskinesia, that is the diagnosis, and valbenazine is the drug. So acute dystonia, option A, acute dystonia is not treated with ropinirole, which is a dopamine agonist again, right? Acute dystonia is usually treated with drugs, such as promethazine or clonazepam, right? So we don't use ropinirole. Akathisia is definitely treated by propranolol, but akathisia is not the diagnosis here. And this is not just oral tremor. It is not oral tremor, right? So the answer here is valbenazine, as we saw in the last slide. Now, this is a question which I think is going to be difficult even for a person who is a psychiatry postgraduate. So it's one of the most difficult questions in the set of questions. A patient says that he follows the way birds fly whenever he is in an open place because God is giving him instructions through the birds. What is the diagnosis? So the question should have been not the diagnosis. A better, question would have been, what is this symptom? Okay, because these are not diagnoses that we are seeing in the options. These are symptoms. So first of all, he is seeing birds, which is a real perception. So definitely visual hallucination is ruled out. Because, in a visual hallucination, there is a false perception. So there is no real perception. So it is clearly mentioned in the vignette that he is seeing birds, correct? So visual hallucinations is ruled out. Next, is it a delusional memory? A delusional memory is when the delusion is in the memory. For example, if a patient says that when I was young, I used to use a spoon. Okay, so he is 35-year-old now. So at 35 years age, he says that when I was young, I was using a spoon which had a crown on the spoon. So that's why I know that I am a king. So he was all right till 35 years of age. He remembers that, he has a memory of using a spoon with a crown. And now because of that, he says that he is a king. That is an example of delusional memory. Here, the case vignette clearly says that he is seeing birds and he thinks that the birds are giving instructions to him. So it is not delusional memory also. Now, option A, when you think of delusional perception. So delusional perception, there should be two components. So we say two-memberedness is important. Two-memberedness. So what do you mean by two-memberedness? One is there is a real perception, okay, or a normal perception, and the individual gives a delusional interpretation to the perception, right? So now the confusion here is between option A and option D. Okay, let's discuss which would be a better option, because both seem to be fairly okay as answers, but I would say one is the best answer, and I'll explain why. So one is two-memberedness is important. So there is a real perception and there is a delusional interpretation. If in this case vignette, if it was written that he saw the birds in the sky, okay, and as soon as he saw the birds in the sky, he immediately got this belief that he is God, that would have been a very good description of delusional perception, right? But what you can see in the case vignette is, he is seeing the birds and he has this belief, abnormal belief, that the birds are themselves giving him instructions from God. So clearly there is a delusion, okay? And we assume that probably he is experiencing this for the first time, because sudden delusional idea is a form of primary delusion. That is, in a person who is healthy, does not have any pre-existing delusions or hallucinations, a person develops these abnormal beliefs. So because he is having this abnormal belief that the birds are, when he sees the birds are giving instructions to him directly, there is a sudden delusional idea. So the answer is not delusional perception, because as I explained, there should be two-memberedness. There is a normal perception, and then that normal perception is there, plus he develops an abnormal belief instantaneously, okay? And the correct answer here is sudden delusional idea, right? So what you have to remember is, visual hallucination is definitely not correct here. All the other options, delusional perception, delusional memory, and sudden delusional ideas, are all primary delusions. And the best option to choose here would be sudden delusional idea. Moving on, Mr. K was brought to a psychiatrist by his friend, saying that Mr. K needs everything to be in perfect order and has difficulty in getting rid of things stored with him. He has something like a hoarding kind of behavior. He is not able to throw away things which are of no meaningful significance to him, both of which are affecting his work quality. So there is dysfunction that you see. He is a perfectionist, right? So it's a personality style, right? Perfectionism. But Mr. K says that, I don't have any problem, my friend has brought, because he is seeing all these things. So what is the diagnosis? Is it narcissistic personality disorder? No, because in narcissistic personality disorder, the individual has, is very boastful, thinks very high of himself, is looking for admiration from others, he is very touchy and gets angry over very small trivial issues. It is not narcissistic personality disorder, right? Is it paranoid delusion? No. So there is no belief in this person, Mr. K, that, somebody is going to harm him, somebody is going to malign him, right? There is no paranoid delusion. Is it dependent personality disorder? In dependent personality disorder, the individual is excessively attached to someone for all their needs. So, and they are very submissive, and they can go to any extent to ensure that they are not abandoned, and they have constant reassurance and constant assistance from a certain person. So this is not dependent personality. So the answer here is obsessive compulsive personality disorder, or also known as anancastic personality disorder. So what is anancastic personality disorder? The individual has great need for symmetry, perfection, cleanliness, rules, regulations, moral values. They are very rigid, very stubborn in their ways, right? So if they have to catch a train, they have to go 15 minutes earlier or half an hour earlier. They have to keep their room clean. Things have to be in a certain place. But they have to stick with moral and religious values, and they also expect everyone around them to stick to those values. And if there is anything that goes a little here and there, they get very upset, right? And all these things, what will happen is, it will affect their work, it will affect their relationships. That is anancastic personality disorder, and the answer here is that. A patient presents to the emergency room with recent loss of memory. So there is recent loss of memory, right? Or maybe some disturbance in recent memory, we can think like that. This person claims that she lost her father due to a road traffic accident 2 weeks ago. So there is this is very important here. It's just been 2 weeks that she has lost her father in a road traffic accident. So basically there is a traumatic event, right? So why do I say it's a traumatic event? Because it is catastrophic in nature, right? Sudden and catastrophic in nature, life threatening, right? So somebody losing their father suddenly, it can lead to lot of distress, right? It's life threatening in nature. And what is happening after that to this patient is, she's having frequent flashbacks. So what are flashbacks? So maybe she was in the car or the vehicle with the father in the road traffic accident, and the person is getting some flashes of that accident, right? So how the car collided with their car, or how after the accident she saw her father, bleeding to death maybe, right? So such frequent flashbacks are there. These are very vivid images, right? Images, when I say imagery, I mean these can be, images in the visual sense, or it can be sounds also sometimes, right? And this has been happening for 2 weeks. So what is the diagnosis? So is it post-traumatic stress disorder? That is the first question we have to answer now, right? For concluding that a person has post-traumatic stress disorder, the symptoms should be lasting for at least 1 month or more than that, right? So which is not seen in this person. So this is not post-traumatic stress disorder. Also, to establish post-traumatic stress disorder, there is need for other symptoms also, right? For example, patients may have nightmares, patients may have exaggerated startle reflex, right? And all, they would be avoiding, say, going to that accident spot, or getting into a vehicle, or getting into a bus. They may be avoiding traveling, so avoidance is seen. There is a lot of anxiety, right? All those things are not mentioned in the case vignette, first of all, and also it is only for 2 weeks that these symptoms have existed. So post-traumatic stress disorder is ruled out. This is definitely not major depressive disorder, because where is sad mood, anhedonia, lack of pleasure, fatigability, which are the hallmark symptoms of depression. So it is not a major depressive disorder also. Is it dissociation disorder or dissociative disorder? See, in dissociative disorder, the individual presents with certain dissociative symptoms. What are dissociative symptoms? There may be, disconnection, lack of connection between normal functions of your body and mind. Say, for example, here, one thing that raises the question of dissociative disorder is because this person is having some lack of or loss of memory, right? So there is an entity called as dissociative amnesia also, okay? But in dissociative amnesia, it is only restricted to memory loss, whereas in this person, there are flashbacks also. That is one thing. And dissociative disorder, we frequently see other problems, such as a person who is not able to lift their hand, a person who is not able to speak after a stressful event, correct? And also we have to remember the incident here is of traumatic nature or catastrophic nature, which I think rules out dissociative disorder. And the best answer here is acute stress disorder. So why is it acute stress disorder? Because it is sudden and acute in nature. Right after the road traffic accident, this person has developed these set of symptoms, and the symptoms have lasted only for 2 weeks. So moving on to the next question. A patient is brought in by a social worker. So after a recent earthquake, so there is again a very stressful event that has happened in the person's life. He has been living in a town different from his place of origin. So basically he has moved to a completely different place, and he is unaware. This person doesn't know how he has traveled so far, 110 kilometers he has traveled from his home. And another thing that is mentioned here is he cannot recollect his identity. So he is unable to remember his identity. Okay. So there is a stressful event, a major stressful event such as the recent earthquake in his area. Then he is moved to a completely different place. He is unaware how he has moved. He does not identify himself to be the person who he is, and he has probably taken up a new identity, a completely new identity. He may be living with a different name. He may be doing some work which is completely different to what he is doing normally, right? And another piece of important history is there is no substance abuse. So it is not due to substance intoxication, or he is not in delirium. For example, a patient with alcohol dependence syndrome may go into a state of delirium, and they may be having such cognitive impairment and confusion that they don't know where they are going, right? But such a thing would appear only if there is history of substance use. There is no history of substance use. So what is the answer here? Is it dissociative amnesia? There are 2-3 things here. It is not just memory loss. He has traveled to a completely different place. He has taken a new identity. He doesn't remember all those things. So it is not just dissociative amnesia, although amnesia is part of this problem, right? But it is not just dissociative amnesia. Is it dissociative identity disorder, DID? No, because it is not just this person has taken a different identity. Okay, in dissociative identity disorder, multiple identities live in the same person, right? And one identity doesn't know about the other identity, so only people who are observing the person will come to know that this person takes up a completely different identity. Okay, and is it selective amnesia? No, it's not just amnesia. So the answer here is fugue, because the clincher here is traveling, traveling to a completely different place which the person is not aware of, right? So such a journey that a person takes is called as dissociative fugue. And what you see in dissociative fugue is a person takes up a completely different identity, and as you can see clearly here, all these are dissociative disorders and they occur after a stressful life event. Okay, so the answer here is dissociative. The most appropriate answer is dissociative fugue. A 21-year-old female presents with amnesia of events following her father's death in a road traffic accident. So this is a slightly different version of the same question that we saw earlier. So father's death has occurred in a road traffic accident. Symptoms have persisted for 2 weeks, experiences flashbacks, right? So there is amnesia of events, and as we saw already, this is definitely not PTSD, because it is, the duration is only for 2 weeks, correct? And it is not dissociative disorder, because you don't have the classical dissociative symptoms, and also this patient is experiencing flashbacks and she has experienced a catastrophic event. This is not major depressive disorder, so the answer here is acute stress disorder. Moving on, under the POXO Act. So what is POXO Act 2012? It is the Protection of Children from Sexual Offences Act, right? It's a very progressive act, which came in 2012, right? And it also changed a lot of things on how sexual offences are seen by the Indian laws. So which group is protected by this law? That is the question. So it's a forensic psychiatry question. Okay, is it children under age 16 years of age? See, why they have asked these options, all children they have mentioned, girls under 16 years age or girls under 18 years of age. What we have to remember is POXO Act, the standout character of this act was that this was gender neutral. That means earlier Indian laws did not appreciate that even male children can be involved in sexual offences. They can also be victims of sexual offences. So this act is first of all gender neutral. So that means the options C and D are immediately ruled out. It is not only girls who are protected, even boys are protected. We know from epidemiological data that male children also go through these offenses, right? And is it below 16 years of age or 18 years of age? We know very well that anybody who is less than 18 years of age is a child or an adolescent, correct? So all children under the age of 18 years is the correct answer here. Option A is not correct. So as we saw all these questions, so there is a major focus on schizophrenia, trauma related disorders, personality disorders and forensic psychiatry. And what I have tried here to help you to conceptualize, right? So how can you rule out different options by ensuring that your concepts are very right? So hope this was helpful. Thank you for joining.